Good evening. Today we'll be discussing about a quick revision series in medicine for gastroenterology subject. So this revision will be useful for undergraduates who are preparing for competitive exams like NEET or NSET. So gastroenterology, most of the things will be covered in the surgical sections like tumors, mass, etc. So here we'll discuss a few tables from Harrison which are relevant to medicine alone. We will not be discussing in detail only the important things in medicine alone. So about the symptomatology of gastrointestinal symptoms. So we know that the GIT starts from the mouth till the anus. So we have many important divisions there. So we have the esophagus, we have the stomach, then the small intestine. Small intestine has different parts: the duodenum, jejunum, and the ileum. Then we have the large intestine. The large intestine also has the cecum, the ascending colon, transverse colon, descending colon. Then we have the sigmoid colon and the rectum. And lastly, it ends with the anus. So even though this is a very basic concept, revising this may be useful because esophageal disorders usually present with swallowing difficulty or dysphagia. Painful swallowing is called as odynophagia. So odynophagia and dysphagia both are symptoms of esophageal disease. Of course, there are other symptoms also. They can cause pain, especially esophageal pain can mimic cardiac type of pain. Stomach usually produces nausea, vomiting. Something called as dyspepsia. And pain is very typical of stomach. Okay. Then we have something called as melena. Melena is nothing but bleeding from the upper GI tract. So what is upper GIT? Up to the ligament of Treats is upper GIT. So bleeding from the upper GIT, usually there will be acid in the stomach. So there will be digestion of the blood. So this lead to black tarry stools. That is called as melena. So tarry, blacky, foul smelling, watery stools is called as melena. Contrast to this is called as hematochezia. Hematochezia is fresh blood from the GIT or fresh blood in stools. It is usually a problem with the lower GI bleeding. So upper GI bleeding presents with melena. Lower GI bleeding presents with fresh bleeding because the acid cannot digest the blood and there will not be change in the color. There will not be black tarry color. So this is called as hematochezia. Vomiting of blood is called as hematemesis. Usually hematemesis is a problem with the esophagus. So that can be told here. Hematemesis is a symptom of esophagus. When we say hematemesis or when there is GI bleeding, upper GI bleeding, there are two types of bleeding: variceal bleeding and non-variceal bleeding. We will discuss what are varices later. So small intestine, usually the symptom will be diarrhea. Large intestine also usually there can be diarrhea or there can be constipation. So knowing these basic differentiation is important to help us understand better. So we'll just read through this. Abdomen pain can occur anywhere, right? It can be a problem with the esophagus, it could be a problem in the stomach, it could be a problem with the intestine. So this is abdomen pain is non-specific. Nausea and vomiting, usually it's a problem of the upper GIT. Okay, nausea and vomiting can occur due to non-GI conditions also, like even diabetic ketoacidosis can cause vomiting. So medications, GI obstruction, like there are many diseases which can cause vomiting. Even pregnancy can cause vomiting. But if vomiting has to occur as a symptom of GIT, it is usually upper GI. And diarrhea, we discussed, it is a problem with the small intestine. Large intestine. Of course, there are other causes of diarrhea also, like hyperthyroidism also can cause diarrhea. Some endocrine tumors like VIPomas, they can cause diarrhea, but we are discussing only the gastric causes. And GI bleeding, we discussed, we have upper GI bleeding, lower GI bleeding. Upper GI bleeding presents with melena or hematemesis. Lower GI bleeding presents with hematochezia. Upper GI bleeding can be variceal and non-variceal. So that is what is summarized here. Non-variceal bleeding can be because of ulcers, hemorrhoids, diverticulum, vascular lesions, esophagitis, etc. Jaundice we'll discuss separately. So this is just a gist. So diarrhea can also be associated with malabsorption in small intestine. So this is just a gist here. We'll be discussing subsequently one by one. So just this basic symptomatology was revised to help us understand the scope proceedings further. Now something about scopy. So we have upper GI endoscopy, also called as OGD scopy, and we have colonoscopy. So two important scopies in GIT. So why we usually do scopy? To directly visualize. So can be helpful in bleeding disorders, can be helpful to diagnose pain. So there are so many investigations, and mainly we can do procedures also through. Colonoscopy may be discussed here because there is something called as screening colonoscopy. So what is screening is, we know that colorectal cancer is common nowadays, especially in some diseases like FAP, familial adenomatosis polyposis, and HNPCC, that is hereditary non-polyposis colon cancers. So usually some of these diseases, there will be a familial association. So rather than waiting for the person to develop symptoms and develop cancer, we can screen them from a particular age. So cancer screening, colonoscopy has a very important role. Right? Apart from the other therapeutic and diagnostic indications, we also have cancer screening. Anemia is a indication for both upper GI scopy and endoscopy, because if a person, for example, a male person who has anemia, especially iron deficiency anemia, because iron is taken through the diet and it is lost only through stools. There is no other way iron can be lost from the body. So if there is iron deficiency, either intake is low or there is loss through the GIT. So if a male person whose intake is fairly normal has anemia, especially iron deficiency anemia, definitely there is a loss through the GIT. It could be upper GI bleeding or lower GI bleeding. Cancer could be one of the reason. Ulcers could be one of the reasons. So any male with anemia, or in fact any GI symptom plus anemia, is a red flag. Okay, GI symptom plus anemia is a red flag. Right? That's why anemia, we have to do both the scopies, upper GI scopy and lower GI scopy. Dyspepsia or swallowing difficulty, we have to do upper GI scopy, and diarrhea we have to do colonoscopy because it's a lower GI symptom, right? So apart from all indications, remember anemia is one indication where we have to do scopy, and think of cancer screening. Then we have some procedures like endoscopic retrograde cholangiopancreatography. It is both diagnostic as well as therapeutic for pancreatic. What is capsule endoscopy? The upper GI scopy or OGD scopy, as the name suggests, it's esophago-gastro-duodenoscopy. UGI scopy covers only up to the duodenum. Colonoscopy visualizes the rectum, sigmoid colon, descending colon, transverse colon, and even up to the cecum. Up to the cecum, the colonoscopy can visualize. But what is left off? Jejunum and ileum is left off. So how can we visualize jejunum and ileum? Because jejunum and ileum, their disorders, as we know, can cause diarrhea and malabsorption. So if also they can cause LGA bleeding, right? So when there is a bleeding or when there is an anemia, when both the scopies, upper GI scopy and lower GI scopy, do not reveal any findings, then we have to visualize this one. That is through capsule endoscopy. Right, so if you understand which organ, which part of the GIT you have to visualize, then you can understand capsule endoscopy. So that's why the term obscure bleeding is given. There is anemia, upper GI scopy is normal, lower GI scopy is normal, but still there is evidence of bleeding. That is stool shows occult blood positivity, then we have to do capsule endoscopy. And suspected Crohn's disease of the small intestine, because jejunum and ileum is commonly involved. So this is what we are discussing about screening colonoscopy. So different books give different recommendations. So this recommendation is taken from Harrison medical textbook. So do you want to screen a asymptomatic individual more than 45 years? They are called as average risk patient. That is person who has no family history, who has no symptom, there is no genetic diagnosis of FAP or HNPCC, still we can do colonoscopy every 10 years. But this colonoscopy every 10 years is invasive. So we have other methods. For example, we can do just a stool occult blood. Okay, this stool occult blood is also done every 5 to 10 years. Or we can do CT colonography. Right? So every 10 years colonoscopy. Suppose they have a history of polyp. So already suppose colonoscopy was done, they have history of polyp. Then we have to classify the risk of the polyp. For example, there is something called a sessile polyp. Sessile polyp has high risk of malignant transformation. Similarly, multiple polyps. If the number of polyps is more, the risk is more. So if there is heavy risk, we have to do repeat colonoscopy every 3 years. So that's what is given. Sessile polyp, large polyp, more number of polyps, we have to do colonoscopy every 3 years. Suppose the risk is medium. There is a sessile polyp, but still the size is less, then we have to do colonoscopy every 10 years. Small polyps and pedunculated polyps, so these have very little risk of malignant transformation. So for them, colonoscopy every 10 years is enough. For one case, we have to do colonoscopy every 6 months following removal of a sessile polyp. So sessile polyp has a high risk of malignant transformation. So that is what is given. So when such scenarios are given for you to understand, just you have to think the risk. An average risk or a low risk every 10 years is enough. Moderate risk 5 years once is enough. High risk every 3 years or even less than that. Remember IBD. There are two diseases in inflammatory bowel disease, ulcerative colitis and Crohn's disease. In that case, there is very high risk of malignant transformation. In that case, we have to do colonoscopy every 2 years. So for polyps, we discussed every 3 years or 5 years or 10 years depending on the risk. But for IBD, every 1 to 2 years, we have to do the risk. And this is what about we discussed the familial diseases. Familial adenomatosis polyposis or HNPCC. For FAP, we had to do colonoscopy every 10 years, we had to do colonoscopy annually. So like in ulcerative colitis or Crohn's disease, we had to do colonoscopy annually starting from 10 years. Similarly, in HNPCC, we had to do colonoscopy every 2 years starting from 20 to 25 years. Right? So this is just a gross approach for screening colonoscopy. This will be discussed detailed in surgical discussions, but just revising the concepts. So I will go to the GIT one by one. So first we will start with esophagus. So as we discussed, odynophagia or dysphagia is one of the symptoms of esophagus. There are obviously many reasons. There are functional disorders, there are structural disorders, there are strictures. So can you identify this image? So this is a barium swallow image. Barium swallows, we make the person drink a barium contrast and we make them swallow. While making them swallow, we take an imaging of the chest so that we can see the esophagus. So normal esophagus will not look like this. This esophagus is dilated. Even though the esophagus is dilated, there is an acute uniform narrowing here, and this is the stomach. So this acute Smooth narrowing is called as bird beak sign. Right, bird beak sign. This is a classical of achalasia cardia. What is achalasia cardia? Achalasia cardia is a esophageal motility disorder where the distal esophageal neurons, the distal esophageal meningeal plexus neurons are permanently constricted, and there is dilatation of the proximal esophagus. So the distal esophagus is constricted and the proximal esophagus is dilated. That is what we are able to see here. So as a result of this, what happens? The food finds it difficult to enter the stomach because the distal esophagus is contracted. Solid food can go through by the effect of gravity. It can open the esophageogastric junction and it can go to the stomach, but liquid diet doesn't go through. Right? This is very typical of achalasia cardia. So persons will be able to swallow solid food, but there will be difficulty in swallowing liquid food. So liquid dysphagia. Always remember, solid plus liquid dysphagia is a structural disorder like a stricture or a malignancy or a mass. Liquid dysphagia is almost always neurologic. So one cause of neurologic dysphagia is obviously achalasia. Because why esophageal motility disorder occurs? Because there is a problem with the neuron, problem with the meningeal plexus, right? So suppose the same picture, same dilated esophagus with an irregular connection, irregular OG junction is called as rat tail sign. It's a sign of esophageal malignancy. Right? So same two issues. So I told you in malignancy, what will be the clinical picture? There will be difficulty in both solids and liquids. So both solid and liquid dysphagia in an elderly person with some high-risk features like anemia, weight loss, fever, plus rat tailing sign, think of malignancy. Relatively young person with a liquid dysphagia, same picture with smooth OG junction with bird beak sign, we call it as achalasia cardia. So this is just another picture to show corkscrew pattern. Corkscrew pattern of esophagus in barium swallow. This is typical of diffuse esophageal spasm. So there are actually 3 esophageal dysmotility disorders. One is the famous achalasia cardia, which we just now discussed. Next we have nutcracker esophagus. And third we have diffuse esophageal spasm. Diffuse esophageal spasm produces corkscrew appearance in barium swallow. So that was about swallowing difficulty and about esophageal dysmotility. What is important about GERD, gastroesophageal reflux disease? Whenever we think of gastroesophageal reflux disease, one word automatically comes to our mind, the Barrett's dysplasia or Barrett's esophagus, where there is the esophageal squamous metaplasia. Esophageal squamous cells become the adenocells and they have a chance of transforming into malignancy. So usually GERD is because of lax lower esophageal sphincter. That can be due to many reasons. Normal lower esophageal sphincter pressure is 25 centimeters of water. So there are some conditions which can exceed the pressure. For example, in obesity, a full stomach, etc. can open the lower esophageal sphincter. Or some conditions like stress, excess coffee intake, caffeine, etc. cause relaxation of the lower esophageal sphincter, which predispose to GERD. So how will you treat GERD? We have to cause acid suppression of the stomach. There are many drugs for that, like H2 blockers, PPI, which I'll show you the table later. The other group of drug is prokinetics. The prokinetics are dopamine D2 antagonists like domperidone or metoclopramide. Whenever you think of dopamine, always think about the neurology. There are many places where dopamine comes in neurology because dopamine is the antagonist for prolactin secretion. Dopamine is the main neurotransmitter in substantia nigra, and deficiency of which causes Parkinsonism. And dopamine has a role in mood and schizophrenia. So anti-dopaminergics will have some effects in the brain, right? It can, when dopamine is suppressed, prolactin will increase. So there will be hyperprolactinemia, especially metoclopramide, because domperidone usually acts only on the peripheral, that is the gastric cells. Metoclopramide has some CNS action. So there can be hyperprolactinemia, there can be mood changes, and when dopamine is suppressed, there will be Parkinson's-like syndrome. So that is called as dyskinesias. These can occur with prokinetics. So that's why the next category of prokinetics came, that is 5-HT3 antagonist. Sorry, 5-HT3 agonist. So serotonin agonist. Examples include ondansetron, palanosetron, etc. So these are some prokinetics. Yeah, some other drugs, etopride, levosulpride. So whether it is 5-HT3 or D2, some of these drugs will act on that to cause prokinetic. This is the usual treatment for prokinetic. But when the reflex into the esophagus is not from the stomach, and the esophagus is inflamed due to other reasons like eosinophilic infiltration or bile reflex, that causes refractory GERD. So when GERD does not respond to the usual treatment, it is called as refractory GERD. Some of the causes are, see, the eosinophilic esophagitis. This pattern is called as feline esophagus. You can see the multiple ring-like appearance. This is called as feline esophagus. Here you can see the next picture, you can see the white curd-like deposits. This is candidial esophagitis. This is a giant big ulcer associated with HIV. There is something called a Schatzki's ring. So these are some other conditions which are usually seen in endoscopy. Suppose if scenario gives a picture like GERD, there's a burning of chest, but it is unresponsive to the routine measures, think of some of these conditions. Okay. That finishes esophagus. Now we'll continue with gastric. Whenever we think of stomach, automatically ulcer or the word gastritis or peptic ulcer disease or acid peptic disease automatically comes to our mind. And we remember this image from physiology. So the stomach has chief cells and parietal cells. Chief cells secrete enzymes like pepsin. Parietal cells secrete hydrochloric acid. This is another image of the gastric parietal cell. So whenever we think of the parietal cell, we always remember the H plus K plus ATPase pump, or also called as proton pump. Because this proton pump or H plus K plus ATPase pump is the one which is inhibited by PPIs. Now we have newer categories apart from proton pump inhibitors, that is PCABs, proton competitive blockers. So usually PPIs will have this proton pump inhibitors are called as hit and run drugs. Because once proton pump inhibitors like omeprazole, esomeprazole, pantoprazole, rabiprazole, if some of these drug is given and it binds to the K plus H plus ATPase pump, it never leaves off. Right? So it inhibits the channel forever. So till the next channel is produced, the inhibition will last. So this is not good, because if there is a downregulation of one of the receptors, automatically the other cells or the other receptors will overproduce H plus. So there will be a rebound of acid secretion in the night. That is the problem with PPI. That is, it's a hit and run drug. It causes permanent inhibition of the H plus K plus ATPase pump. This causes rebound acid production. So this PCAB is competitive acid blockers, right? Because of competitive acid blockers, they attach and detach from it, so it is reversible. So they say the newer PCABs are more effective. So we have some drugs like vonopressin, fexupressin, right? At least remember they are a group of drugs called PCABs, which are better than PPIs. And we have multiple extra things which act on the cells. Remember gastrin. When gastrin increases, acid secretion increases. That is why we have some tumors called as gastrinomas. Gastrinoma is one of the neuroendocrine tumors like Vijayakumars. When gastrinomas are there, gastrin is more. Gastrin stimulates acid production. We have acetylcholine, histamine. They also have some influence. We are not discussing that. At least remember gastrin, because gastrin is very important. There are many other influences. We will skip this. Okay. So we have discussed about the acid production and what influences acid production. One important, very, very important cause of acute gastritis or even chronic gastritis is H. pylori gastritis, Helicobacter pylori gastritis. So Helicobacter pylori is a spirochete, like leptospirosis, etc. Helicobacter pylori is a spirochete. This spirochete is present in the stomach, and by many mechanisms it causes gastritis. Like it secretes many enzymes, it secretes porins. So one enzyme which is produced by Helicobacter pylori is urease. Then we have CAG-A and VAC-A. At least remember these three: urease, VAC-A, and CAG-A. So when this is present, when a bacteria is present for a long time, what happens? There will be inflammatory response. So the bacteria is producing porins, urease, VAC-A, CAG-A, and there is inflammatory reaction in the stomach. All these leads to chronic infection or chronic inflammation or chronic gastritis. This chronic gastritis leads to ulcer. Whenever some chronic infection is there, what happens? Acute infection, neutrophils and macrophages come. Chronic infection, lymphocytes come into play. So when chronic lymphocytes are there, those lymphocytes accumulate and it forms gastric maltoma, mucosa associated lymphoid tissue lymphoma. Also, chronic infection is one reason for cancer. So H. pylori is very important because it causes acute gastritis, it causes chronic gastritis, it causes gastric carcinoma, gastric adenocarcinoma, it causes gastric maltoma. It's a lymphoma. So that is why this H. pylori is very, very important. In fact, if you see, gastric maltoma usually reverses on treating H. pylori itself. So you need not give lymphoma treatment. They say gastric maltomas till a particular stage, it is enough if you treat H. pylori, the maltoma can reverse. So this is again the same diagram which shows the progression. See, bacteria is there, H. pylori is there. It is in the normal gastric mucosa. So acute infection becomes chronic infection. So by the host factors and by the bacterial factors, it causes acute gastritis, chronic gastritis, it causes ulcers. So two cancers can occur. One is gastric cancer, another one is lymphoma, malt lymphoma. So since H. pylori is very important, it is always essential we have to diagnose H. pylori. So we have invasive test and non-invasive test. So what is invasive test? We discussed one of the indications for OGD scopy is patient is having dyspeptic symptoms. So once we do an endoscopy, we can take a biopsy. Biopsy, if you do a silver stain, we can see tissues there. But we can do rapid urease test while doing endoscopy itself. So we do an endoscopy, we can take a tissue and do rapid urease test is there. It is nearly sensitive. So why urease? Urease is one of the enzyme which is produced. What is this urease test? When the tissue is put in urea, it breaks and generates ammonia. Ammonia is actually an alkali. So it produces change in pH. So rapid urease test is diagnosed from a endoscopy tissue. The same non-invasive counterpart of urease test is urea breath test. The thing is, the concept is simple. The same thing. The person is having urease in his stomach. So when given urea, what happens? Urease breaks down the urea and generates ammonia. When ammonia is breathed out, it will cause a change in pH. Right? So that is called urea breath test. And we can do H serology also. H. pylori can be checked. H. pylori, IgM levels can be checked. And H. pylori can be checked in the stool also. Okay. So how will you treat gastritis? So one drug we already discussed, proton pump inhibitors. So it acts on the H plus K plus ATPase pump. It is a hit and run drug. So the next category is PCAB. So the latest edition of Harrison doesn't mention PCAB. So the drug is vonoprazan. So omeprazole, lansoprazole, rabeprazole, panto. So all these are proton pump inhibitors. The earlier drug was H2 receptor blockers. H2 is histamine blockers. So I showed in an earlier diagram, acetylcholine, histamine, gastrin, all these three have a positive influence on acid production. So when histamine is blocked, histamine is a substance which increases acid secretion by stimulating H plus K plus ATPase. When histamine is blocked, acid will be reduced. So ranitidine, famotidine, older drug was cimetidine. Cimetidine went out of favor because of its multiple drug interactions. It is a cytochrome. It is a cytochrome P450 CYP3A4 inhibitor. So that's why it went out of favor. So this H2 blockers and PPIs, the mechanism is must to remember. Antacids, they are just neutralizing agents. Right, Gaviscon, they are neutralizing agents. Then some drugs like sucralfate, they only coat the GIT. They coat the stomach and prevent acid from refluxing. Yeah, bismuth compounds are also mucosal protective agents. Bismuth is very important because there is a regimen in H. pylori called as bismuth quadruple therapy. So this is regimens for H. pylori. So till now we discussed about the drugs commonly used in gastritis. Now for H. pylori we have to give obviously PPI because PPI are very effective drug, plus we have to give some antibiotics. So usual regimen is clarithromycin triple regimen. Clarithromycin 500 mg BD, amoxicillin 1 gram BD and pantoprazole BD. So usually it comes as a kit. So clarithromycin 500 BD, amoxicillin 1 gram BD and a PPI like lansoprazole BD. Of course, in place of amoxicillin, metronidazole can be used. We can use tetracycline. We can use levofloxacin, right? So many regimens are there. Like if one regimen fails, we can use the other regimen. So clarithromycin triple is the commonly used one. We have bismuth quadruple. Quadruple is 4 drugs: PPI, bismuth, tetracycline, and metrozole. So there are so many regimens. Levofloxacin. Usually when the first regimens fail, we go to the last regimens are levofloxacin based regimens. Usually these levofloxacin based regimens form a part of the rescue regimens. When there is recurrent H. pylori, we can give levofloxacin based regimens. Amoxicillin, instead of clarithromycin, we give levofloxacin and PPI. Okay. So this is also one thing which we are discussing. So in the initial symptoms, we were telling about anemia with gastritic symptoms, especially anemia in a male, iron deficiency anemia in a male is a red flag sign in GIT. Because the only route by which iron is excreted through the body is through the GIT. If there is iron deficiency anemia, definitely there is some gastric pathology. So what are the other red flags or alarm symptoms? Age more than 40 years, presence of anemia, presence of weight loss or fever, emaciation. So if some of these symptoms are present, we are supposedly to send the patient to gastroenterologist, right? At least remember this one. So if a scenario is given, if we're able to pick up some red flag feature in the imaging, we have nothing to do. We have directly to refer them to the gastroenterologist who will plan all the scopies, OGD scopy, colonoscopy, or if both turn negative, we can also plan capsule endoscopy to identify the source of bleeding, etc. Suppose none of these alarm features are present, we always have to rule out H. pylori. So we need not do an invasive endoscopy to take a biopsy and do a silver stain or do a rapid urease breath test rapid urease test to diagnose H. pylori. Non-invasive H. pylori like H. pylori antigen testing in the blood or stools or the urea breath test, this alone is enough. So if there are no red flag signs, we can do a rapid urease test, that is non-invasive HP testing. If it is positive, we can treat and confirm eradication. Suppose if this test is negative, just a trial with a blocker is enough. And remember the next step which we discussed, suppose there is improper response to PPI or H2 blocker, think of refractory causes of gastritis like eosinophilic esophagitis, bile reflex esophagitis. Likewise, we have many other reasons. See, these are the other reasons. So we discussed acute H. pylori gastritis is one reason. Suppose if H. pylori is negative, we are supposed to give H2 blockers or PPI. But suppose if there is inadequate response, some of these will be usually present, like lymphocytic, eosinophilic. Think of Crohn's disease in refractory gastritis, granulomatous gastritis, sarcoidosis, etc. One important cause of refractory gastritis is gastrinoma. We'll discuss that shortly. So when things last for a longer time, we call it as chronic gastritis. We have two types of chronic gastritis, type A, type B. Type A for A for autoimmune gastritis, B for H. pylori gastritis. So I told you one of the reasons for refractory gastritis is gastrinoma. Gastrinoma is a gastrin producing tumor. It's a neuroendocrine tumor, usually associated with MEN1. MEN1 in endocrinology we usually discuss. Multiple endocrine neoplasia type 1 usually produces all the P's: pancreatic tumors, pituitary tumors, parathyroid tumors. Apart from that, we also can have gastrinomas. So how can you suspect gastrinomas? There is refractory gastritis. There are multiple ulcers in unusual locations. See, for example, esophageal ulcers plus duodenal ulcers plus gastritic ulcers, right? There is a family history, recurrence of ulcers, and there is basal hyperchlorhydria. That is, HCl secretion is high even without stimulation. Plus there is unexplained diarrhea. Why diarrhea occurs is excess acid, excess HCl, it breaks the pancreatic lipase. When lipase is broken down, fat absorption is problematic, so it leads to steatorrhea. So multiple ulcers plus diarrhea, think of think of gastrinomas. So that finishes about stomach, the important medical aspects in stomach. Now we'll come to the intestine. So when we think of intestine, I told you the important syndrome here is diarrhea. Whenever we think of chronic diarrhea, acute diarrhea is usually infective. Subacute diarrhea is also usually infective. When diarrhea is lasting more than 4 weeks, it is called as chronic diarrhea. Always when there is chronic diarrhea, we should think of malabsorption as one of the causes. There are many causes, like Vijayakumar is one cause of chronic diarrhea. Mass active intestinal peptide secreting tumors. So it's a secretory diarrhea. Of course, there are some chronic infections in the GIT, but malabsorption has a very special place in diarrhea evaluation. So that's what we are going to discuss now. So when there is malabsorption, the mechanism can be due to 3 things. 1, there is reduced luminal secretion of a particular enzyme. when there is reduced luminal secretion of an enzyme, obviously digestion is going to be abnormal and there is going to be diarrhea. Next we have problems with the mucosa itself. When the mucosa is damaged, for example, diseases like celiac disease or diseases like radiation enteritis, when the mucosa is damaged, obviously it cannot secrete, right? The third, the mucosa is normal, but there are some genetic abnormalities where the secretion in the lumen is normal, the mucosa is normal, but beyond that the absorption is abnormal. So we can say it as defective absorption. Example for this will be A beta lipoproteinemia. Beta lipoproteins are needed for absorption of triglycerides from the GIT. When triglycerides are absorbed, they form chylomicrons. When beta lipoproteins are problematic, this process will not occur, so there will be steatorrhea. So this is the three categories which we discussed. One, there is inadequate digestion due to reduced secretion. There can be problems with the mucosa, like in celiac disease or Crohn's disease. And third, there is problems with the nutrient delivery. So example will be A beta lipoproteinemia. I think this will be clear. See, in chronic pancreatitis, what happens? There will be reduced secretion of enzymes like lipase. So this is a reduced mucosal secretion. Then there can be problems in the mucosa itself. Example, celiac disease. Or there can be problems in the post-absorptive phase, like in A beta lipoproteinemia. Okay. So maybe we'll go through some diseases. Exocrine pancreatic insufficiency is one important disorder causing malabsorption due to reduced secretion of enzymes will be this pancreatic insufficiency. Example is chronic pancreatitis. Remember, when there is chronic pancreatitis, there will be exocrine pancreas problem as well as endocrine pancreatic insufficiency. Endocrine pancreatic insufficiency means there is reduced insulin, so it leads to diabetes, pancreatic diabetes. And chronic pancreatitis causes exocrine deficiency, causing diarrhea or steatorrhea, pancreatic CA, and cystic fibrosis is one important disease. Cystic fibrosis, there will be problem with the cystic fibrosis transmembrane receptor channel, which is a chloride channel. When it is problematic, there will be excess secretion in some places, there will be reduced secretion in some places. So here usually there will be increased secretion of chloride causing diarrhea. So gastronoma we discussed, because of inactivation of lipase there will be diarrhea. So coming to the other diseases affecting the mucosa, we have something called small intestinal bacterial overgrowth. Right, small intestinal bacterial overgrowth. Then about mucosal disorders, the most important disease is celiac disease. Celiac disease, there is gluten intolerance. So here there is increased IgA levels or antibodies against tissue transglutaminase. Okay, so it's like a sort of autoimmunity. It damages the mucosa, causing diarrhea. So there will be villus atrophy. This will be the biopsy finding. We have an infection called Whipple's disease. Tophrema whippleyi is an infection causes diarrhea, and we know that post Whipple's disease diarrhea there will be GBS. Okay, radiation enteritis is other condition damaging the mucosa. And folate and vitamin B12. Folate and vitamin B12 are very important vitamins needed for mucosal proliferation. So when these vitamins are deficient, there will be problems and diarrhea. Some infections like giardiasis also affect the mucosa. Graft versus host disease affects the mucosa. Apart from this, we have Crohn's disease, storage diseases like amyloidosis, lymphomas, right? So if someone asks about mucosal diseases, think about celiac, think about Whipple's, radiation enteritis, B12 deficiency, giardiasis and GVHD. Right. So apart from that, we have some endocrine diseases also cause diarrhea, like adrenal insufficiency, hyperthyroidism cause diarrhea. But this is not our scope. We are discussing pure GIT now. Like celiac disease. So celiac disease, I told there's a problem with the gluten. IgA is high. Anti-TTG is high, tissue transglutaminase. So here treatment is, the initial stages it is gluten-free diet. If it is severe, we can give steroids. Similar to this celiac disease, we have something called as tropical sprue. Celiac disease also called as celiac sprue. We have tropical sprue, like diseases like giardiasis, etc. These tropical infections can lead to diarrhea. That is called as tropical sprue. So now quickly going through some clinical manifestations. So if a scenario is given, how can you pick up that there is a particular malabsorption? So why knowing particular malabsorption is important? I'll just give you one example. Remember mnemonic. Dude is just feeling ill, bro. So D is duodenum. Duodenum is the site of iron absorption. Jejunum is the site of folate absorption. Ileum is the site of B12 absorption. So some diseases affect some parts, and when the particular part is affected, a particular mineral will be affected. For example, celiac disease, which we just now discussed, there will be villous atrophy predominantly affecting the duodenum. When the duodenum is affected, which mineral is not absorbed? Iron is not absorbed, so there will be iron deficiency anemia. So if a scenario is given, there is a history of diarrhea and there is iron deficiency anemia on evaluation or examination, we have to think of celiac disease. Now, one disease which affects the ileum predominantly is Crohn's disease. Okay, Crohn's disease and tuberculosis, these are two important diseases which affect the ileum. I told you ileum is the site of B12 absorption. So if there's a Crohn's disease or TB, of course there will be diarrhea, but which vitamin will be deficient? B12 will be deficient. So there will be symptoms of B12 deficiency. So this is the reason why we must know the clinical manifestation of a particular vitamin or a mineral deficiency, right? So this is about vitamin and mineral. What about macronutrients? So carbohydrate deficiency or carbohydrate malabsorption usually causes, when carbohydrates are not absorbed, they get fermented by the intestinal bacteria to give dyspepsia or flatulent dyspepsia. So the test here done is D-xylose test. What about fat malabsorption? When fat is not absorbed, it leads to steatorrhea. Steatorrhea is fat in stools, right? Here we have 72 hours fecal fat estimation. Usually proteins are not affected because protein digestion occurs throughout the GIT. So usually proteins are not affected in malabsorption. So usually weight loss, malnourishment will be there. That is the common symptom. And diarrhea is usually the symptom of malabsorption. I told you flatulent dyspepsia is the symptom of carbohydrate malabsorption. To prove that, we have to do D-xylose test. And glossitis, chelosis, stomatitis, think of iron deficiency, B12 deficiency, folate or vitamin A deficiency. If there is a clue telling that there is a background of abdominal pain, pancreatitis will be more likely. Bone pain, calcium is deficient, okay? Calcium, vitamin D, malabsorption, etc. Tetany and paresthesia, again calcium deficiency. If there is weakness, think of anemia. And anemia, always think of iron, folate or B12 deficiency. Iron deficiency anemia, think of celiac disease because duodenum is the site of iron absorption. Celiac disease usually affects the duodenum. If there is anemia with B12 features, think of Crohn's disease, which is a type of IBD or tuberculosis. If there is bleeding, think of vitamin K malabsorption. Remember, vitamins A, D, E and K, these are fat-soluble vitamins. So these are fat-soluble vitamins. So So when fat soluble vitamins are not absorbed, when there is fat malabsorption. So there is a background of steatoria. Example, chronic pancreatitis is a disease which causes fat malabsorption because lipase is deficient. So there is steatoria, there is abdomen pain, there is history of diabetes because of endocrine pancreatic insufficiency. There is problems in the eye, nyctalopia, night blindness. Vitamin D is deficient, so some bone changes are there. Vitamin K, as we know, is the cofactor for synthesis of clotting factors 2, 7, 9 and 10. So there are some bleeding tendencies. Then obviously you can think of chronic pancreatitis, right? So background of abdomen pain, patient is having diarrhea, steatoria, night blindness, bone changes and bleeding. Always think of chronic pancreatitis because of fat malabsorption. B12 and thiamine, there will be peripheral neuropathy. Obviously, B6 also can cause peripheral neuropathy. But these are usually water-soluble vitamins. Okay. So again, what are the biopsy findings? So these may be given as clues in scenario. Whipple's disease, we know it's an infection which damages the mucosa. So what we have? PAS positive bacteria. Okay, macrophages with PAS positive material. A beta lipoproteinemia, I told there is normal level. It's not a problem with the mucosa, there is problem with the post mucosal absorption. So we have vacuolated fat filled with vacuoles in the biopsy. And what about Crohn's disease? It's a non-caseating granuloma and we have something called cobblestone appearance. What about celiac disease? Villus atrophy. Okay, and there is lymphocytic infiltration. Like H. pylori causing maltoma in the stomach, the celiac disease can also cause maltoma in the duodenum. So celiac disease produces multiple symptoms. There are multiple points to remember. And we discussed about tropical sprue. Tropical sprue is similar to celiac sprue. Only thing is the cause is different. Celiac disease is due to anti-tissue transglutaminase antibody. Tropical sprue is due to intestinal worms. Bacterial overgrowth, small intestinal bacterial overgrowth. The bacterial overgrowth will cause damage to the villi and there is lymphocytic infiltration. And radiation enteritis. Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is multiple gastrinoma or MEN1 syndrome. So as we know, it causes gastritis in multiple sites with diarrhea with elevated gastrin levels. Okay. So now coming to inflammatory bowel disease. So that finishes malabsorption. Now coming to inflammatory bowel disease, again it involves both the small and the large intestine. So this is the one which is given in Harrison. So one important point to remember here is smoking prevents ulcerative colitis, but it causes Crohn's disease. So if you have seen one episode of Dr. House where he will prescribe smoking for patient with ulcerative colitis. And OCPs increase the risk of Crohn's disease. Okay, somehow you should remember this. Smoking causes Crohn's disease, but it prevents ulcerative colitis. Similarly, oral contraceptive pills cause Crohn's disease, but it has no increased risk in ulcerative colitis. Now, what is the site usually affected in ulcerative colitis? So the name itself suggests colitis, which means the distal colon is affected. So the rectum, sigmoid and the descending colon. These three are commonly involved in ulcerative colitis and this is usually involved continuously. So the entire distal colon is involved, right? That is why we have some picture called as toxic megacolon. In Crohn's disease, what is typically involved is anus and ileum. So anus, it can cause anal tax, which is a clinical sign which you have to pick up. And in ileum, as we discussed, it causes multiple problems. So we'll discuss the other differences. So ulcerative colitis involves the colon. Usually distal colon is commonly involved. Rectum is definitely involved. If one organ you have to remember, ulcerative colitis is rectum. Crohn's disease is the anus and the ileum. And ulcerative colitis is a continuous inflammation. So the rectum, sigmoid colon and the descending colon is completely involved, and it is only a submucosal involvement or a superficial involvement. And there is crypt abscesses here. It's a pathological finding. Contrary, we have skip lesions in Crohn's disease. Just remember, I told you ileum is involved, anus is involved. There is no direct connection between these two organs. So there is a patchy involvement of the GIT. It is called a skip lesion. Then you have to think of cobblestone. Cobblestone is a pathological appearance. So crypt abscesses occur in ulcerative colitis. Cobblestones occur in Crohn's disease. Then non-caseating granuloma. So caseating granuloma is tuberculosis. There are some diseases causing non-caseating granuloma like cat scratch disease, sarcoidosis, etc. One of the diseases is Crohn's disease. Crohn's disease causes non-caseating granuloma. So if histopathology is given, all these things you have to find out, right? And it's a transmural inflammation. In ulcerative colitis, only there is superficial involvement of the mucosa. Here, the entire cross section of the histology is involved, from the mucosa up to the serosa. Since it is completely involved, it has high risk of forming strictures, right? So skip lesions, stricture formation, non-caseating granuloma, cobblestone, all this is Crohn's disease. Continuous superficial crypt abscesses is ulcerative colitis. So how will the symptoms of ulcerative colitis be? There will be diarrhea, right? And colonic diarrhea, always remember, there will be mucus and blood. So bloody mucoid diarrhea. Crohn's disease, of course, there is diarrhea. Bloody diarrhea is there, but the most important finding here is there can be malabsorption plus perianal lesions. It's what I told you, and there can be intestinal obstruction. Why? Because strictures can form, right? So left side colon is involved, or left iliac fossa shows some findings. Think of ulcerative colitis. If the right side colon or right iliac fossa shows findings, think of Crohn's disease. Treatment is basically the same. We give aminosalicylate, sulfasalazine, mesalazine, etc. Then we can give steroids. Sometimes steroids are kept as enema. And then we have biologicals, and finally surgery. So smoking prevents ulcerative colitis. Smoking prevents ulcerative colitis. That is one point to remember, and this table is also very important to remember. So these are the 5 aminosalicylic acid preparations. So remember sulfasalazine, mesalazine. These two are the commonly used drugs. And we have many biologicals. So once steroids fail, we have to give biologicals. So infliximab, adalimumab, we have discussed as TNF alpha inhibitors. We have natalizumab is an anti-integrin monoclonal antibody. Anything which ends with mab is monoclonal antibody. Natalizumab is anti-integrin monoclonal antibody. Whenever we give natalizumab, we have to monitor anti-JC virus. There is a virus called JC virus. It's a polyoma virus. This virus can get reactivated. So before giving natalizumab, we must always check anti-JCV antibody. In fact, before giving any biological in rheumatology, etc., always we have to check for latent TB. How can we check for latent TB? By doing either a Mantoux test or quantiferon TB Gold. And we have to rule out active hepatitis B. We have to check for HBsAg. So One extra thing in giving natalizumab is we have to check anti-JCV and JC virus antibody also, right? And when giving biologicals, they should be vaccinated against flu, pneumovac, etc. Because it's an immunosuppressant, strong immunosuppressant. Ustekinumab, it's an anti-interleukin 12 and interleukin 23 antibody, also used in psoriasis. Tofacitinib is a JAK inhibitor. JAK is Janus kinase. It is a downstream signaling molecule for most tyrosine kinase receptors. So JAK, right? So infliximab, adalimumab, certolizumab, they are TNF-alpha antagonists. We have natalizumab, anti-integrin antagonist, and ustekinumab, it's an interleukin 12 and 23 antagonist, and tofacitinib is a Janus kinase inhibitor. Now, what are the prerequisites for testing? So the treatment approach is simple. In the initial stages, we are going to give only sulfasalazine, which is a 5-aminosalicylic acid, or mesalazine, and local colonic budesonide, which is a steroid. And whenever the disease is active, we are going to give prednisolone. When the disease is active, we are going to give injection methylprednisolone, or injection of steroids. Suppose when the disease is mild or in remission, we give oral steroids like prednisolone. Suppose patient is not responding to injection or oral of steroids, we are going to give biologicals, or we have second line drugs like methotrexate or azathioprine. So this is the summary of the entire thing. Just you can go through. Now don't get confused between IBD and IBS. IBD is inflammatory bowel disease, which is Crohn's disease or ulcerative colitis. IBS is irritable bowel syndrome. Many people get confused here. IBS is one of the functional bowel disorders. Functional bowel disorder doesn't mean that the patient is acting. It means there is not a structural disease or there is not a pathological disease which causes this symptom. So there are multiple pathogenesis which is postulated. One is the leaky gut dysbiosis, that is the person is having a different gut microbiome totally. Okay, we are not discussing the entire pathology here. It is said that compared to normal healthy individuals, people with IBS have a different gut microbiome. They may have visceral hypersensitivity. Again, it is not a disease. Compared to other people, they are more sensitive. That is why taking some foods can trigger diarrhea in some. And motility abnormalities and gut-brain interaction. So endocrine dysfunctions or neurogenic dysfunctions, all these can be related. So some genetic predisposition is there, some psychological disposition is there. So IBS is a functional GI disorder. So the definition is there is recurrent abdomen pain, right? So pain is an important criteria in IBS. At least 1 day per week in the last 3 months with at least 2 of the following criteria. The pain has to be related with defecation. Related means either the pain is increased with the defecation or relieved with the defecation. It increased with defecation or relieved with defecation. There is a change in the frequency and change in the consistency of stool. So consistency of stool is either stool is loose stool or hard stool. So as change in frequency of stool is either there is diarrhea or constipation. Right? So there is abdomen pain at least 1 time per week for the past 3 months. The pain is either increased or decreased with defecation. There may be either diarrhea or constipation, or there may be loose stools or hard stools. Most important thing is all other diseases are ruled out. This is the most important prerequisite. Okay, for example, I am telling a person having abdomen pain, chronic abdomen pain for the past 6 months. He is having bloody diarrhea daily. Okay, this picture mostly goes in favor of a Crohn's disease, right? So until and unless you rule out Crohn's disease, unless you rule out the other diseases, you cannot say that it is IBS. So if a person comes with diarrhea, don't label them as IBS directly. We have to do a complete evaluation. We have to rule out infections. We have to rule out celiac disease. We have to rule out tropical sprue, small intestinal bacterial overgrowth, ulcerative colitis, Crohn's disease. Once all are ruled out, patient fits the criteria of Rome 4, then it is called as IBS. So what are the drugs which can be given? I told you there is either diarrhea or constipation, so the drugs also varies. So if there is diarrhea, we are giving drugs to reduce the bowel motility. Loperamide is a drug which is given. We have resica-dotril. So both these are opioids which cause constipation. Suppose if there is constipation, we can give multiple drugs like lactulose can be given, right? Polyethylene glycol can be given. All these have multiple effects. If you remember, laxatives have different names like osmotic laxatives. Lactulose is an osmotic laxative because when lactulose is given, lactulose is a sugar. We know very well that when sugar is not absorbed, it will be acted upon by the gut bacteria to produce more of intestinal gas. So that will cause some osmotic effect causing diarrhea. So lactulose is an osmotic laxative. Then you have stimulant laxatives. Example, prucalopride. Right? Prucalopride or bisacodyl. These are stimulant laxatives. When the bowel motility itself is low, we can use stimulant laxatives. Then we have stool softeners. So the psyllium husk, methyl cellulose, these are some fibers. So they soften the stools. Okay, so stool softeners, osmotic laxatives, stimulant laxatives are there. Lubiprostone and linaclotide, if you remember, these are two drugs which are used in cystic fibrosis. This lubiprostone is a chloride channel activator. The chloride channel which is affected in cystic fibrosis is CFTR. So CFTR activator is lubiprostone. Linaclotide is a guanyl cyclase stimulator. Guanyl cyclase stimulator. When this is stimulated, there will be excess secretion, right? So this is for the diarrhea and constipation part of IBS. But the first criteria is there is abdomen pain. So how will you give an abdomen pain? Smooth muscle relaxant like dicyclomine. These are antispasmodics, right? SSRIs can be given because there are some psychological components. So SSRIs are tricyclic antidepressants are given. And for the diet, think of probiotic diet like curd, etc. and low FODMAP diet, fermentable oligosaccharides, disaccharides, monosaccharides. So example, apples, etc. are low FODMAP diet. Onion is a high FODMAP diet. They cause some gastric discomfort. Rifaximin is a drug which is used nowadays. Rifaximin, mechanism of action, it's a non-absorbable antibiotic. This non-absorbable antibiotic kills the bacteria and kills the abnormal bacteria in the GIT. So it helps with the gut dysbiosis. Dysbiosis is treated. If you remember, the same rifaximin is the drug which is given in cirrhosis. So in cirrhosis, one mechanism for hepatic encephalopathy is the intestinal bacteria act upon the diet which is taken to produce more of ammonia. So when the bacteria are killed by this rifaximin, that process is reduced, right? So a small discussion about intestinal or mesenteric ischemia. So whenever ischemia is there, think of the word postprandial angina. So wherever the term ischemia comes, be it ischemic stroke, right? There are only two pathologies of ischemia. One, there could be embolism. So how does embolism occur in the mesentery? For example, person is having an atrial fibrillation. He has a high chance of developing a left atrial clot. That gets dislodged and it goes and blocks one of the intestinal arteries like a superior mesenteric artery or inferior mesenteric artery or celiac artery. So patient develops abdomen pain. It is a cause of acute embolic mesenteric ischemia or intestinal ischemia. Then comes thrombotic. Thrombosis means it's a long-term process where the blood vessel gets narrowed. So one clinical feature of this thrombosis is, in peripheral arterial disease we call it claudication. In coronary artery disease we call it a stable angina. In Mesenteric ischemia, we call it as postprandial angina. So there is abdomen pain following food intake. So if there is abdomen pain following food intake for a long time, it means there is some thrombosis which is occurring, right? So that is what is given here. Arterial embolus or arterial thrombus. These are the two reasons for mesenteric or intestinal thrombus. If there is an embolization, definitely there is something which is going on. So we have to anticoagulate. Cardioversion, because I told you atrial fibrillation is the one common cause of embolic source. Plus we can do surgery to remove the embolus. Suppose if there is a thrombus, again anticoagulation we are going to give, but thrombus is a usually local phenomenon. This is about arterial thrombus and arterial embolism. We also have venous thrombus and venous embolism, not to get confused much. Anyway, the treatment is going to be anticoagulation anyway, right? Now about malnutrition. So we are discussing about the vitamin and macronutrient malnutrition, mineral malnutrition and vitamin malnutrition. This is just a revision, right? So what happens in thiamine deficiency? The clinical finding is beriberi. Beriberi is of two types, dry beriberi and wet beriberi. Dry beriberi, there is only neuropathy. Wet beriberi, there is cardiomegaly, that is heart failure. So when there is heart failure, there is edema, that's why it's called as wet beriberi. Right? Usually it causes the famous syndrome which we know, Wernicke's syndrome. Right? So if you think about the mechanisms why this are occurring, thiamine is very important in intermediary metabolism, like pyruvate dehydrogenase pathway in biochemistry. One of the cofactor is thiamine, right? Thiamine pyrophosphate. So in persons like alcoholics or in persons with chronic diuretic use, persons who are chronically vomiting, they cannot take food, or who are chronically starving, they are more prone for thiamine deficiency. Thiamine causes dry beriberi in the form of neuropathy or Wernicke syndrome, Wernicke's encephalopathy. If you remember Wernicke's encephalopathy, there is a triad, GOVA. This triad occurs in the same order. Global confusion, ophthalmoplegia, means there will be diplopia usually, and ataxia. So this triad, global confusion, ophthalmoplegia, ataxia, is called Wernicke's encephalopathy. If it continues to progress, it leads to something called as Korsakoff psychosis. Korsakoff psychosis. In wet beriberi, there will be cardiomegaly. Riboflavin is easy to remember, usually causes stomatitis, magenta tongue, cheilitis. Niacin, remember the word pellagra, the 3D, diarrhea, dementia and even death. Diarrhea, dementia, dermatitis and death. B6 causes glossitis and it causes convulsions and neuropathy. Okay. Folate and B12, we told they have very important role in proliferation of cells. So when folate is deficient, it leads to megaloblastic anemia. When B12 is deficient, it leads to megaloblastic anemia, right? And B12 and folate have a very important role in converting homocysteine to methionine. Okay, there are only 2 or 3 important biochemical functions of B12. One important function of B12 is to convert homocysteine to methionine. There is something called S-adenosyl methionine. So that is the cofactor here. So when B12 is absent, this homocysteine to methionine conversion does not occur and homocysteine accumulates. Excess homocysteine accumulation leads to many problems in the body. One among it is it can cause premature stroke, etc. Vitamin C deficiency causes curl. Vitamin A deficiency causes xerophthalmia, night blindness, bite spots, etc. This will be discussed in ophthalm. And vitamin, remember A, D, E and K are the vitamin fat soluble vitamins. So in diseases like chronic pancreatitis or any condition causing fat malabsorption, these are problematic. So vitamin D causes deficiency, causes rickets. Vitamin E deficiency causes peripheral neuropathy, and vitamin E deficiency causes ataxia, right? Neuropathy and ataxia, just remember that. Vitamin K there will be problems with the vitamin K dependent clotting factors 2, 7, 9 and 10. So there will be bleeding. Right, so just a small revision about that. Similarly, we have micronutrient deficiencies. Calcium is a micronutrient. We know that it causes osteoporosis. When copper is deficient, it leads to problematic hair growth. Copper deficiency, there is a genetic syndrome called as Menkes kinky hair syndrome. Menkes kinky hair syndrome. Right? So copper deficiency. We know the problem with copper excess, which is Wilson's disease, right? So that's what is given in the right side. Copper excess causes the hepatolenticular degeneration, which is called as Wilson's disease. Copper deficiency causes Menkes kinky hair syndrome. Of course, there are some other things also, osteopenia, etc. Fluoride deficiency causes dental caries. Fluoride excess causes fluorosis, where there is increased bone. Fluoride deficiency causes dental caries and osteoporosis. Fluoride excess causes osteosclerosis. Iodine deficiency, we know that it causes hypothyroidism. And iron, we know it causes anemia. Selenium causes cardiomyopathy. Zinc causes gonadal problems, diarrhea and dermatitis. So it's called acrodermatitis enteropathica. So maybe you can just give a short read through this. It will be self-explanatory only. So the gist of this is what vitamin deficiency causes what problem and what mineral deficiency causes what problem. Only if you know that, you can pick up clues regarding malabsorption. Now pancreatitis again. So when GIT we discussed about esophagus, the stomach, the small intestine, large intestine. But I didn't mention about the solid organs in the GIT. Solid organs do not come directly a part of GIT because the liver and biliary tract is a separate system altogether. Because liver and biliary tract, what are the symptoms it causes? Jaundice is a very important symptom of the biliary tract. Then we have variceal bleeding. Okay, we have a separate session on this also. There is variceal bleeding. Plus there is a mass, hepatomegaly. These are the symptoms of liver and biliary tract. Pancreas is also a solid organ. We have discussed till now about chronic pancreatitis. So when there is chronic pancreatitis, we have two types of deficiencies, right? One is endocrine deficiency. And the other one is exocrine deficiency. Endocrine deficiency causes diabetes. And if you remember, among the classification of diabetes due to pancreatic deficiency, we call it as type 3C diabetes. Exocrine deficiency is all the pancreatic enzymes, especially lipase. When lipase is deficient, there will be steatorrhea or fat malabsorption. It is diagnosed by the 72 hours fecal fat estimation. And the fat dependent vitamins A, D, E and K deficiency will be there, right? So this is what we discussed about pancreas till now. Another solid we have kidney. Kidney is a separate discussion. So what are the causes of acute pancreatitis? Again, pancreatitis is mainly a surgical topic. To discuss about the causes, alcohol is a cause, gallstones causing obstruction is a cause. Among the medical causes, hypertriglyceridemia. Usually when triglyceride level is more than 1000 milligrams per deciliter, it can cause pancreatitis. Remember ERCP. We discussed about endoscopic retrograde cholangiopancreatography. It is a very important diagnostic and therapeutic tool to diagnose most of the pancreatic tools or an obstructive jaundice. Okay, ERCP is a diagnostic and therapeutic tool in pancreatic diseases and obstructive jaundice, but post ERCP itself, they are more prone for developing pancreatitis, right? So this can be asked as a scenario. So following ERCP, if they develop some abdomen pain, always think of post ERCP pancreatitis. And we have some uncommon causes. Some drugs can cause pancreatitis like sodium valproate, aspirin, then we have azathioprine, and hypercalcemia is one reason for pancreatitis. When there is recurrent pancreatitis in children, think of congenital disorders like pancreatic divisum. We have hereditary pancreatitis. In India, we have something called as tropical pancreatitis. Especially following tapioca intake, we have something called tropical pancreatitis. Some infections can cause pancreatitis like mumps pancreatitis. We have autoimmune pancreatitis. Trauma can cause pancreatitis. Okay. So just about the few causes of acute pancreatitis. And chronic pancreatitis, we usually call it as chronic calcific pancreatitis. Because once pancreatitis becomes chronic, definitely there will be lymphocytic infiltration followed by fibrosis. That fibrosis leads to calcification. So we discussed already, there will be exocrine pancreatic insufficiency and steatoria. There will be diabetes mellitus, that is type 3C diabetes mellitus. Apart from that, chronic abdomen pain. Usually this will be the easy to identify clinical type. And there will be metabolic bone disease. Why? Because of vitamin D malabsorption. And when chronic pancreatitis is there will be strictures in the duct, pseudocyst, etc. And long-term chronic disease always leads to cancer. Right. So the further details may be discussed in surgical sections, like how will you treat chronic pancreatitis, what are the surgeries available, what is phrase procedure. So these are surgical discussions. So with this we finish the short medical discussion of gastroenterology.